two, one. Please start, ma'am.
Namaskar and good evening, everyone. I welcome you all for today's webinar on ovarian cancer, present and the future. And with immense pleasure, I would like to invite Dr. Major General B.N. Kapoor, who is Director Medical Oncology, Yashoda Super Specialty Hospital, to set the ball rolling and to take the proceeding further. Over to you, sir.
Thank you very much, and good evening to all. It's my proud privilege to be a part of this eminent Zoom meet, ovarian cancer, the present and the future. Ovarian cancer is a very common cancer in female, and it amounts to about 8 commonest cancer in the female. Very commonly, we see the patients in the age group of 45 to 80 year of age, where it is very common. And the survival of ovarian cancer is about 30 to 50% 5-year survival. They do relapses, goes into remissions. Many multi-drug has been used in the treatment of ovarian cancer. 75% of these patients are being diagnosed as an advanced stage of the cancer, and 70% of the female do relapses. So there are a lot of options available for the treatment of ovarian cancer. The main risk factor for development of ovarian cancer is the family history. If there is a first relative having the ovarian cancer, the chances of development of ovarian cancer in the family member is very high. Of course, nowadays the mutational analysis by BRCA1 and BRCA2 mutation and HRD has been found to be very common, and about 15 to 20% of the patients we found this mutation, BRCA1 and BRCA2. The treatment of ovarian cancer dates back to 2003 when the chemotherapy, taxane and cystatin came in the management of ovarian cancer. And subsequently, the first paradigm shift happened in 2011 when bevacizumab came as part of the treatment for ovarian cancer. Subsequently, in 2018, the PARP inhibitors, and 2019, PARP inhibitors beyond BRCA mutations have been found to be effective in the management of ovarian cancer. To discuss all these things and the newer modalities in the management of ovarian cancer, we have got eminent speakers today. And to start the talk, I would invite Dr. Prashant Bagali. He is the head oncology from Strand, and he will be speaking on moving from BRCA to HRD, what is new in this mutational analysis. So I request Dr. Prashant Bagali to please start his talk on what's beyond BRCA.
Yeah. Good evening. Thank you.
Bagali,
yeah. Is my slide visible?
Yes, sir.
Thank you. At the outset, I thank the AstraZeneca and the Spring Hope Cancer Foundation for giving this opportunity to share my view. And I thank all of you for this wonderful session, and they're very neatly organized in this. So since my presentation will also be a continuation or probably a pretext of the Dr. Chaudhary's presentation, the next one. So I'll just try to put only the concepts which we are hoping on the how does the initial BRCA, what was exactly was covering in the BRCA, and then how it exactly has been now to the level of HRD, which is the new way of looking at the first line treatment and all. So here just I cover the important points, the fundamentals of it and all. So where I will know the timer, or I need to keep the timer. Just I was curious. Okay, so because I cannot see the timer, but yeah, I'll just try to cover as fast as possible and also. Okay, fundamentals and the hereditary cancer syndrome and the why HRD is important in the treatment of ovarian cancer and all. So this is the one which all of you are familiar. So the whole of our genomics, medical genomics and clinical genomics is going around with this. So here mainly what we are interested is the one which is the bioinformatics analysis, because the genetic information, once it comes, the way we look at into the variants and the way we do the interpretation play a very important role. So rather than the the understanding the biology of the whole concept. So this is the one, a very important one with regard to the biological function and the symptoms. And also, this is from the perspective of the fundamentals, that what are the different stages in which in this in the modern genomics one we can see. So, for example, earlier the testing was leading to the reduction of the disease incidence, but now the secondary testing prevention and the tertiary prevention has been very prevalent, wherein the testing leads to the early disease detection and interventions and all. So, and tertiary prevention is where testing that leads to the personalized treatments and all. So, this is very important in terms of Dr. Kapoor said that in terms of the incidence rate is being increased now drastically. So, it's very important to cover these two segments in our discussion and all. So this is another just a fundamental slide, because whenever I get the queries in my discussions, always the questions will be on the HRR, HRD, what are the differences and how exactly from the NGS panel these two are different. And also, although that's the different scope of it, but what I would like to share with you is whenever I see the discussion, only the doctors ask is the gene, whether this gene is covered or not. But what I would like to share here also is not only the gene here in perspective, but also what are the other disease causing variants of that particular gene are also included in the panel what you are going to have, or in the genomic a panel which we are targeting and all. So it may be an SNP. If it is only SNP is covering, good, it is, because it's easy to catch and then take the further clinical outcome and take the further diagnosis, prognosis or choice of therapy and all. But along with that, there are a couple of more genetic alterations and which are also very important. So in our next presentation, probably Dr. Chaudhary will cover all those SNVs and LOH and all. But here I'm just sharing the complexity in which we are dealing with in this breast cancer and the ovarian cancer. So in the hereditary cancer syndrome, basically there are multiple things which we need to understand from because BRCA initially started with the breast cancer. So here the more than 50 hereditary cancer syndromes are basically either directly or indirectly related to this BRCA1 and 2, and most of them are the tumor suppressor genes, and some of them are the DNA repair genes or mismatch repair genes. So that is where you will able to have the other non-conventional markers like HRD or TMB, the MMR and MSI and all. So, but here the hereditary cancers, or most of them are autosomal dominant and have a incomplete penetrance, and some of them have a complete penetrance and all. So the common ones are the BRCA1 and 2, which is 5 to 8% of the breast cancer. But the important here is for us how the breast cancer has been participating as a main causative agent or a tumor gene in breast cancer, ovarian cancer, pancreatic cancer, and melanomas, multiple melanomas, and prostate cancer and all. So I will not go in depth with this, but this is just to share that how the BRCA earlier, when it was identified, was playing a very important role in these different clinical categories or cancer types and all. So, and BRCA1 and 2 are associated cancers, which is more than 5 to 8% in breast cancer. And they also play a very important role in the DNA repair genes, because we have around primary ones is around 11 DNA repair genes, and also we have around altogether 43 genes in the human, which are either directly or indirectly related or impacted by the BRCA1 and 2. So the lifetime risks I have just shared just as a from the perspective of the academic interest and all. So that's BRCA1, early age onset and the higher cancer risks, and breast and the ovarian cancer. So, but the important point here is in the general population from the perspective of India. So the breast and the ovarian cancer. So BRCA1 and 2 were not so much prominent in from the perspective of ovarian cancer earlier. So in the ovarian cancer, 1 to 2% in the general population risk, but the mutation risk was always there for the BRCA1, so around 24 to 40%, and the BRCA2 is around 11 to 18%. So, and next is rightly we have already experienced in our practice. There are multiple generations which are all involved in this hereditary breast and ovarian cancers. The age onset can be, although this often is 50, but it nowadays starting from age 45 years also. It can be bilateral or multiple primaries are very common, and a family history of unique tumor combinations. So it can be sarcoma, breast, brain in the same family, or male breast cancer and ovarian in the whole family. So this is the important question which everybody asks me, whether we need to go for a single gene testing whenever there is a risk, or we have to go for a multiple gene panel and all. So here, I always see the advantage, if you see from the perspective of a multi-gene panel, it always gives a higher diagnostic yield compared to the single gene and all. So with a limited BRCA1 and genetic test for patients at risk for HBOC and all. So, it also detects the less common or less penetrant genes such as ATM and PAL-B and all, which is very prevalent in Indian population, and around 5 to 10% of the breast cancer cases also cover that, and lower pre-gene test and detects large deletions, sequence duplications, and complex gene rearrangements, and the flexible platform that can add additional genes and improve gene capture and bioinformatics analysis and all. So also it covers with the some of the whatever not so good factors or cons or disadvantages. So higher VUS rates, which has been a debatable topic in many of my one-to-one sessions with the oncologists and the other clinicians, and also the variable or variations of unknown significance, or which have not been annotated properly, or we don't have a proper reference from the perspective of India. So here is where the Strand has done a big repository where we use our own proprietary database to do those annotations. So that's why in the reports you will see less VUS in our reports and all. So I'll just go to the next slide because it's just repetition of that. So as a part of the HBOC, like here I mentioned, so about 70 to 85% of HBOC cases are caused by mutations in either the BRCA1 and BRCA2 gene. So this is like a previous to the BRC or a HRD, I should say, pre-HRD era. So here the testing strategy was, before the HRD, was identifying the mutation by doing either a full gene sequencing and doing a genetic counseling followed by that, or a deletion and duplication of the test for the BRCA1 and 2, either by using MLP or any of those tests and all. And of course, for the family members, the germline panel was always there for mutation detect, and followed by the genetic counseling and all. So if nothing comes out here, then they'll go into the whole genome sequencing, which covers many of these, which I don't recommend the whole genome sequencing, but that is what was earlier followed in the convention and all. But the HRD came into the existence was a great boon to the many of the patients, because HRD just simply mentions the homologous recombination deficiency, which occurs in the genes that regulate the homologous recombination repair pathway, because the human body has an inherent ability to repair itself, and that's where the HRR pathway is there. So that's why I always say the BRCA1 and 2, we need to exactly specify that the mutations or the deleterious mutations cause the disease. If not, they are all the like a recombination repair genes, and they're always present in all the women and also men and women, sorry. So pathway, and here when they are unable to fix only, there will be a deficiency, and that is where the HRD come into the picture. So BRCA testing is not enough, has been identified in the Pavlov study, and also probably in the next speaker will cover all those studies and how the outcome has been established and the cutoff points and all. But the HRD can select more patients who may benefit from the PARPI treatment and all. So because the BRCA1 and 2 was only a narrow with regard to the coverage of the people who respond, and also coverage of the people who had a risk of in their family and all. So for example, the HRD is covering now 50% of those which are having a clinically, which are either positive or who have a risk of bilateral kind of the occurrences and all. So wherein the BRCA was covering only the 20% of it. So in my opinion, the HRD is fast, accurate, and it is needed, and it involves the BRCA1 and 2 also mutations, and optimized SNP probes have been done. So because Strand is routinely been supporting with the AstraZeneca with regard to this, and the drugs have been approved for this HRD positive patients, and that's the one of the, I think, much benefit to the patients and all. So, and only the last slide I just added just to as a continuation for the next presentation. So here, just to give the how HRD is arising from the homologous recombination pathway with regard to the gene mutations. So I've just added this slide, and it is a very elaborate slide for not only for the high-grade serous ovarian cancers, but also on the from the perspective of the other altered HRR gene expressions in the different so either minor gynecological diseases and all. So this is what I thought to share in this today's evening session. So I think we have some time for the couple of questions and all. Yeah, thank you.
Thank you, Prashant. It was very exhaustive talk on BRCA and HRD.
Thank you.
And definitely both the things have to be done. And I find HRD is more specific for the management if we come for the treatment of BRCA mutated and ovarian cancer. And it gives more positivity, I think 50% you said versus 20% in the BRCA.
Yes, doctor. Yeah.
So it is more, I must say, it's more sensitive than BRCA.
Yes, doctor. Because earlier in the BRCA1 and 2, being the high penetrant genes was covering the less population. So many of them were not responding to the drugs which are targeting the BRCA1 and 2. But now with the expansion of this HRD, we have the drugs which are very specific to that. It's like it's like in a court of trial, the more evidences are available now to catch the enemy. So in ovarian cancer. So in that perspective, it's always better to have that window broadening so that more patients will benefit from the drug, doctor. Yeah.
Any questions from anybody?
Good evening, Prashant sir. Thanks for that excellent oration, sir. Sir, I have one question. We are sending so many samples recently for HRD testing, but many of them are turning out that DNA yield is not adequate. DNA yield is not adequate. So can you just elaborate, sir, how it is different from NGS from DNA extraction point of view? Or is it different, or is it the same quality is required?
Yeah, correct. So just to say that the kit what we are using, which is recommended by the AstraZeneca, is the Amoy DX kit. So it has its own medical approvals with regard to the DNA requirement, the DNA quantity and DNA quality of it. So our Strand is a CAP accreditation. So we have a set of in-house QC criteria to be approving a FFPE sample. So once we take a section of it, prostate microtomy section, we analyze for the tumor content. So the tumor content is more than 20 to 30%. So we are approving that. So next stage will be the DNA quantity extraction. So we require around 200 nanograms for this because of the more number of regions what we are covering. And in terms of the quality of that, we use a Agilent tape station, a Dean square, which is the DNA integrity number. So DNA integrity number plays a very important role because of the complexity and also in terms of the specificity and the sensitivity here. So more than 2.5 is what strongly recommended by the Amoy DX in this perspective and all. So however, we also do the amplifiable DNA quantity also. So LUPCR or ALPCR1, which is amplifiable DNA also is a very important one, and we require at least it need to be around 32 or 20 to 30% to be increased and all. So these are the minimum criteria we use, and where the rejections are happening with regard to usually in the FFPE sample, based on my experience in different countries in Malaysia, Singapore and all, where I have worked with my postdoc experience in NIH and all. So it's around 10 to 15% we always see in the FFPE sample, which is more than say 6 to 8 months old, depending upon again the age of the the way it is being preserved and stored and all. So, and that's the one question. But if a fresh sample or say like 3 months old is getting rejected, then the way of preparation of the paraffinization is also play a very important role. So once the surgeon takes out the tissue, biopsy and all, so it need to be preserved in the formaldehyde and preserved neatly. So before it goes to the paraffinization of it, that method plays a very important role, because anything more heat, because the tissues are heat temperature or nucleic acid, basically, which is stored there is very heat sensitive. So if it is stored or if it is prepared at a higher temperature, so instead of arresting the nucleic acid within the cells, and also it might disrupt the nucleic acid. So you will able to see the tumor content, which is very much used in our IHC or ISH like fish assays and all, but it will not be able to give a proper DNA integrity with a proper quantity and all. So that's the only mismatch it is happening, doctor. So if I will get a one-to-one chance, then I will probably be able to talk to the histopathologist who is in charge there, and just to review through their process, so that we'll all in line with that and all. So and certainly from our side, we are improving the different way of extractions also, so that we will able to preserve maximum the DNA which has been fixed in the paraffin embedded block.
Thank you, Dr. Prashant, for a very nice talk, and very informative also. Thank you very much, Dr. Prashant.
Yeah, thank you, doctor. I appreciate this.
We'll move on to the next talk, and I do invite Dr. Colonel G.S. Chaudhary, my good friend. He is the consultant medical oncology in the Western Command Chandimandir, and he will be speaking on leveraging HRD testing to treat ovarian cancer.
Sir, thank you so much for the introduction, sir. I thank the organizers. I thank the program director and Colonel Suresh and General Dr. B.N. Kapoor, the chairman, for this talk. So today I shall be talking about HRD, which is the new test for BRCA, beyond BRCA, and we are bringing precision or a more tailored management to a newly diagnosed ovarian cancer. Around 295,000 patients were diagnosed in 2020 with ovarian cancer, and at least 60% of them have come in advanced stage. The problem with ovarian cancer is it's a disease in the pelvic region, but it doesn't get symptomatic till it comes to undersurface of the diaphragm and causes non-specific symptoms. So unfortunately, most of our patients come in a very advanced stage. 70% of them would relapse irrespective of whatever treatment they get, which is a standard debulking and platinum-based therapy with taxanes. And the 5-year survival would be about 30 to 50%. In fact, in the early stages, the prognosis in stage 1 and stage 2, the 5-year survival is about 90 and 70%. And in stage 3 and 4, they are roughly 40 and 17% respectively. So there's a drastic drop in the survival as the stage advances. We also understand that the first shot at treatment, that means the completeness of surgery, whether it is an R0, R1 or R2 surgery, with a platinum and a taxane, with or without bevacizumab maintenance, is very important to initially look at how long the patient maintains his progression-free survival, and the subsequent survivals will depend on what we do in the first line. Now, we know as per ICON 7 and GOG 2 and 8 that the addition of bevacizumab maintenance has been also a paradigm shift from 2008. And I think somebody's mics. And the outcomes of patients improve with progression-free survival because of bevacizumab maintenance. I think somebody's audio is interfering with my speech. So they're giving a platinum agent with a taxane with bevacizumab, although the standard of care. But in the US, bevacizumab is not used frequently because there was an intent to treat subpopulation analysis, which found that there was no OS advantage by giving bevacizumab in both these studies. So it's controversial to whether bevacizumab will give us a big advantage, but at the current moment, it is the standard of care. And after the first line of treatment, generally patients would do well for about 2 years. And then we would give them second line therapy with a platinum agent with bevacizumab again once they become symptomatic, and expect an 8 to 20 month PFS2 yet again. Gradually, as we go to the third line and non-platinum based therapies, we see that the interval of progression-free or disease-free survival reduces till the stage that the disease has relapsed and becomes largely incurable towards the end. So the major shifts which came after 2003, almost a decade later, the paradigm shift was bevacizumab. And in 2018, we had the introduction of PARP inhibitors for BRCA mutated cancers, as we'll see later in the study called SOLO-1. In 2019, just a year later, the standard of care of bevacizumab in maintenance with a PARP inhibitor beyond BRCA mutation was introduced in the PAOLA-1 study. So as we all understand that if there may be an internal or external insult to the cell externally through radiation, chemotherapy, or other errors, and the internal damage by various replication errors or spontaneous mutations, and these can lead to single-stranded breaks or double-stranded breaks in the DNA. The single-stranded breaks undergo a spontaneous base excision, like a base excision repair. It undergoes a AP endonuclease repair, and this is a high fidelity repair, and it becomes a normal cell once again. The other DNA repair system is a double-stranded break repair, which works through 3 methods, like a homologous recombination repair, or a non-homologous end joining repair, or a micro-homologous mediated end joining repair. Now, the homologous repair leads to, again, a high fidelity repair, and this would ultimately bring about back to a normal cell. And it requires another adjacent chromosome from where this is shared for the repair. In both the other kinds of repair shown in the chart, the cell repair may not be very accurate. The end result is that whatever repair is there, the cell would undergo through a temporary cell cycle arrest, followed by a permanent one, and it will go into apoptosis and cause cell death and prevent carcinogenesis. Now, the ovarian cancer is a very heterogeneous disease, not only histologically, but also molecularly. And we know that the DNA repair mechanisms involve not only BRCA1 and BRCA2 mutations, but they also involve the mismatch repair gene mutations like MLH1, MSH2, MSH6, and the PMS2. There are also the Fanconi anemia gene repair mechanisms, which include the RAD51C, 51D, the BRIP1, the PALB2, and the BARD1, to name a few. Now, 1/3 of advanced ovarian cancers have homologous recombination repair deficiency. That means they are HRD positive. And half of the high-grade serous carcinomas do show this HRD defect. So this is what, once we give multiple lines of therapy, this is what we intend to target. Now, by getting PARP inhibition, it utilizes synthetic lethality, as shown as the last cartoon, that HRD deficient, that means if they have either of these defects and we add a PARP inhibitor to the cell, it will lead to cell death, thereby preventing carcinogenesis and also identifying those patients who have HRD positive in whom PARP inhibition can be given, as opposed to normal cells who undergo daily in our bodies homologous recombination, base excision repair, and undergo cell survival. So we try to identify the cause and effect of HRD. So the cause is because of an underlying mutation either in the BRCA1 or BRCA2 mutations, and we understand 15% of them may be germline and 20% of them may be germline and somatic. Or we look at the HRR other gene mutational tests, which we had earlier missed out in just about a few years ago. We were just doing BRCA1 and BRCA2 testings, but we need to also look at multiple other genes which could be involved in this pathway. The effect of an HRD positive happening would be that it would cause genomic instability in the form of telomeric allelic imbalance, a loss of heterozygosity, or a long strand transition. Now, if we find these which are present along with the mutations above, they are present in more than 50% of advanced ovarian cancer. So what the carry home message would be that we must order an HRD genomic instability panel. And in those newly diagnosed ovarian cancer patients who submit their fresh frozen paraffin emitted blocks, we need to extract the DNA and look at the tumor BRCA mutation and look at these three things, LOH, TAI, and the LST, for looking for genomic instability, which may be present. And this would help us identify that those people who are HRD positive would benefit from PARP inhibition. And when we look for these mutations in the blood, we're looking at germline mutations. And in the tumor, we're looking at germline or somatic mutations. And a lot of guidelines do recommend testing both the germline and somatic mutations. And the homologous recombination genomic scar assay is the one which I feel we should order currently to also look at these three other effects of the thing. So in a newly tested ovarian cancer patient, we should use a clinically validated method to detect HRD, and this would help us to plan therapy. The test, I think Myriad, my choice, was being done earlier. I believe there is some issue, I've been told, of this test at the current moment. So probably somebody will enlighten us about this later. So when we get a patient with ovarian cancer in advanced stage, I would be interested to know in step 1 whether there is a BRCA mutation. If possible, I can extend the panel to do looking at the other HRR genes and the genomic instability and ask for a HRD scar test. I would also be interested in giving bevacizumab in maintenance unless it's contraindicated, like if there is a high risk of perforation or recent surgery or other uncontrolled hypertension, as I mentioned. And then I would stage the patient, plan with my gynae oncologist to give neoadjuvant chemotherapy or undergo primary surgery if the bulk is high and he can't get an R0 or R1 resection, because the completeness of surgery will determine the outcomes, and look at platinum sensitivity beyond HRD status and discuss with the patient that there would be some mild toxicity. So the new thing is olaparib maintenance treatment in a newly diagnosed ovarian cancer is very important. And we must offer this to our patients. We have 2 studies for this, which are phase 3 trials. which is the solo one with olaparib maintenance alone, and the Paula one, which looks into olaparib maintenance with bevacizumab. So we'll first look at the solo one trial, which deals with maintenance therapy with a PARP inhibitor in a newly diagnosed ovarian cancer. And here we took stage 3 and stage 4 high-grade serous or endometrioid ovarian cancers, all those cancers which were diagnosed as primary peritoneal or fallopian tube cancers, understanding that there is a dual cell of origin, either from the ovarian surface or from the fallopian tube fimbriae. We looked at germline or somatic BRCA mutations, and these patients should have a good performance status of 0 or 1. They underwent cytoreductive surgery, either upfront or after NSCT, and thereafter they were randomized in a 2:1 ratio to receive olaparib, a 150 milligram tablet, 300 milligram twice a day, versus a placebo. And they were continued if till disease progression, and many patients at 2 years stopped treatment when they didn't have any evidence of disease, but those who had a partial response could continue treatment. The primary endpoint was the investigator assessed PFS, and secondary endpoints were the quality of life, time to run, overall survival, and PFS reported by the patient, and PFS2. And we see that at 2 years itself, there is in the olaparib arm a 56-month versus a 13.8-month PFS advantage, which is quite significant. This was continued at 5 years, at 60 months, to have an 48% versus 21% outcome. So those BRCA mutated patients in Solo 1 trial who received olaparib had a reduction in progression of the disease. That means we have increased the PFS, or we have reduced any event occurring or death by 67%. And this figure is no small figure. And this thereby shows the importance of giving olaparib to our patients who have BRCA mutations. Solo 1, the adverse effects were tolerable, but most of them were fatigue, anemia, and GI disturbances, which were quite manageable. Now, the other trial which used non-BRCA mutated patients was the Paula 1 trial in the newly diagnosed patients with chemotherapy and bevacizumab. So the patients again were the similar group of patients with advanced ovarian cancers and non-mucinous BRCA mutated cancers who underwent either interval or upfront surgery and had received platinum-based therapy and received at least 3 cycles of bevacizumab. They either achieved partial response, complete response, or no evidence of disease at the end of this treatment. And then they were taken up for bevacizumab maintenance in one arm, and the other arm was given olaparib with bevacizumab in its 2:1 stratification ratio. The primary endpoint, again, PFS, and the secondary endpoints being PFS2, overall survival, safety, and patient-related outcomes, especially regarding quality of life. So we have patients who were now earlier represented, I'll just skip to the next slide, and treating non-BRCA mutated patients, the Paula 1 showed that olaparib and bevacizumab, as you can see that the curves separate very early, had significantly improved the progression-free survival versus giving just a placebo with bevacizumab. And the median PFS was 22.1 months versus 16 months with a hazard ratio of 0.59. So if we look at the subgroup analysis, and both the groups were comparable, and we found that there were about 48% of patients who were HRD positive in the study. The difference in PFS was significant in all the groups shown in red, which used olaparib with bevacizumab, and it was most significant in the third group, which were HRD positive. The clinically meaningful improvement in median PFS of 20 months may increase with longer follow-up. And even in those patients who were HRD, 19% of patients in this group were HRD positive, which were non-tumor BRCA mutated. And we are seeing the PFS advantage in the arm as 28.16, which I've already mentioned. Let's come again. And this benefit seemed to continue beyond the period of study. Treating non-BRCA mutated patients in the PAOLA-1 study significantly reduces the risk of not only progression in the intent to treatment arm in HRD positive patients, regardless of the BRCA mutation status. So we can take home a carry home message that not only is the PFS, but the PFS too also improved in HRD positive patients, regardless of the clinical risk status, all of them, whether they were in 3, 4, or other histological parameters. And this was more significant in the HRD positive population, as shown. So I think I've just come to the last slide, and I will now skip these few slides, which just show that the addition of olaparib to bevacizumab, an anti-VEGF agent, enhanced the clinical response to first-line treatment. The overall response rate, as I already mentioned, was highest in those patients with either BRCA mutation or in those patients which were HRD positive. So the benefit is in this group of patients. And the side effects of which were more great, which led to death, were very, very remote. And most of the side effects were manageable easily, which were mainly hypertension, nausea, fatigue, and anemia. The incidence of new malignancies, MDS and AML, are noteworthy for keeping in our mind. So the takeaway messages from this is that the HRD SCAR test is a new BRCA test, and we must go beyond just testing BRCA1 and 2 in somatic or germline mutations. And it's a key biomarker for predicting the response to PARP inhibitors. So those patients who have HRD deficiency or are HRD positive should be exhibited PARP inhibitors. The SOLO-1 has shown that maintenance olaparib showed a 67% reduction in the risk of disease progression. The PFS of 56 versus 13 months at 2 years, and 48% versus 21% responses at 5 years in the SOLO-1 trial. The PAOLA-1 trial in HRD positive patients showed an improvement in PFS with olaparib with bevacizumab versus placebo with bevacizumab, which was again significant. And this shows that it's important to do HRD testing prior to clinical decision making, and we must start olaparib early in the treatment. There's significant effect improvement of PFS 1 and 2, irrespective of the BRCA mutation status, the clinical risk, or the FIGO disease stage. The HRR and HRD by genomic instability are not interchangeable and are not substitutes for each other for first-line maintenance in ovarian cancer. So thank you very much to the organizers. I think I've finished.
Thanks a lot, G.S. Chaudhary. It was a very informative talk.
Thank you, sir.
I just want to ask one simple question. How many patients of you think will come as BRCA positive and HRD positive? And how many will be BRCA positive and HRD negative? How much percentage do you?
So percentage wise, I think HRD positive patients.
Means both BRCA1, BRCA2 and HRD positive, and BRCA1, BRCA2 positive and HRD negative, and HRD positive and BRCA1, BRCA2 negative. How many of them?
So, sir, in HRD positive would be present in almost as many as 50% of any high-grade advanced ovarian cancer, irrespective of whether it's serous or non-serous histology. In serous histology, of course, the percentage will be about 50%. Those patients who are BRCA negative and HRD positive, I will not be able to give you an exact figure, but I feel that around 30% of about 15% will have germline BRCA1, BRCA2 mutations. and about 30% more we will detect in the HRD positive tests who show other genetic mutations other than BRCA1 and BRCA2. And how many patients show genomic instability? I think I'll not be able to. Maybe somebody else can take it up. I'll not really be able to give it.
And one more simple question. Like PARP inhibitor will be more beneficial if both the things are present, BRCA1, BRCA2, and HRD mutations?
Yes, sir. That's what we are trying to. We are trying to extend the scope of detecting those patients who have either a BRCA1, BRCA2 mutation or a HRR gene mutation. That means if we do just
If
BRCA1,
both are there, if all three other means
then
BRCA1.
PARP inhibitors would definitely act better in either of them. But sometimes why we want to do this HRD scratch test is if those patients who are BRCA1 and BRCA2 negative may still have HRD positive, and those are the patients which will definitely benefit from PARP inhibitors also. So we're just extending the benefit of PARP inhibitors in ovarian cancer.
Thank you, GS. If there is any other question from the panel or anybody, we can ask. If there are none, then we'll move on to the next talk, and I will invite my dear friend Colonel Abhishek Pathak, who is the consultant medical oncology in Calcutta in the Eastern Command Hospital. And he will be delivering his lecture on treating recurrent ovarian cancer going beyond chemotherapy. Colonel Abhishek Pathak, please.
Good evening, sir. It's indeed a pleasure to be speaking in front of my teachers, General Kapoor sir, Chaudhary sir, and it really gives me a lot of pleasure that I'll be speaking in front of them. I would just request Colonel Chaudhary sir to please stop sharing so that I can start sharing my slides. Chaudhary sir. Thank you, sir. So is my slides visible to everyone?
Yes, sir.
Okay, great. So, okay, at the onset, I would like to thank the organizers for giving me this wonderful topic to be speaking on treating recurrent ovarian cancer going beyond chemotherapy. Definitely. So the thought comes up, what is beyond chemotherapy? So the only two things which comes to my mind are probably a set of these PARP inhibitors and probably some anti-VEGF like bevacizumab, or maybe in few cases earlier we had been giving pazopanib. So beyond this, I think there's hardly anything which we give in ovarian cancers beyond chemotherapy. So as my job has already been made very easy by Colonel Chaudhary sir, who had given a wonderful talk on the prevalence, the incidence of ovarian cancers, the action and the way the PARP inhibitors actually work. But nevertheless, I think all of us would agree that among women, the ovarian cancer would be the second most cancer that we do see, and next to the breast. And definitely the treatment is initially in the initial stages very good, but later on with the relapse stages, there's a lot of morbidity involved and mortality involved in managing of recurrent ovarian cancer. So there is always a requirement of what else can we do for these patients. So it is primarily with this intent that there are a lot of developments which have been coming up, and among the best thing that we have in our arsenal as of now are the PARP inhibitors. So as sir had already shown that there is a lot of unmet need in the advanced ovarian cancer likely, stage 3 and stage 4. Till now, we had a platinum doublet we could give with, bevacizumab, give some kind of PFS around 10 to 18 months. But we all know that sooner or later, these patients are going to relapse. And as had already been brought up, around 70% of these patients would relapse. And the 5-year survival is very dismal, though it does vary whether you are stage 4 or stage 3. But overall, 30 to 40% is what the survival that we are looking at. So, so there was definitely a lot of unmet need that needs to be, fulfilled. So this slice appears to be very busy. That too, in the right-hand side of the corner, you see there are a lot of newer drugs which have come up. But if we try to analyze, most of them are just, PARP inhibitors. Those are the olaparib, the niraparib, and the rucaparib. And these business is actually brought in because there have been multiple trials in the first line setting, in the maintenance setting, in the second line. So primarily, we are looking at these different types of PARP inhibitors that have, flooded it has brought in fact, a number of newer trials in advanced ovarian cancers, and they have been initially used, in the first line as a therapy modality and also as a maintenance modality. So a lot of these drugs have come up in last 7 to 8 years. So, but still, what does the teaching say? What does the ESMO and NCCN guidelines say? Because more or less we tend to fall on these. Even if we have a relapse CA ovary and the patient is platinum sensitive, the first and foremost approach is to go for a cytoreductive surgery if it can be done. Then followed by it, we either go to a platinum monotherapy or a platinum-based therapy with bevacizumab, or we can go for platinum-based therapy with a PARP inhibitor maintenance. If we are looking at a platinum-resistant disease, then still the whole idea is to look at, cytoreductive surgery and to go for non-platinum therapy. So these are more or less the broad guidelines. Looking at the NCCN guidelines, here still it's more or less the same. But here we are looking at a cytoreductive surgery in case of platinum-sensitive recurrent disease, followed by platinum-based combination plus minus bevacizumab or PARP inhibitor. And depending on whether you have a germline BRCA mutation, then you go on olaparib, rucaparib, or niraparib, or bevacizumab. So we'll be going into the details. And if you're resistant, then you go for non-platinum-based therapy plus minus bevacizumab. However, other modalities like bevacizumab monotherapy and PARP inhibitors are also there. So this is just a crux of how we would be approaching to a case. And in cases of re-challenge with platinum-based chemotherapy, plus minus bevacizumab or maintenance PARP inhibitor. So what does the ESMO recommendation says? Carboplatinum doublet should be the treatment of choice. Selection between platinum-based doublet, different options should be based on the toxicity profile and administration convenience. Patient with recurrent high-grade serous ovarian cancer and a germline or a tumor BRCA mutation should be offered maintenance olaparib after a response to platinum-based therapy. I think more or less this is what we all do. Vis-a-vis, if we come to NCCN recommendation, so they say combination platinum-based therapy preferred for the first recurrence in patient with clinical or radiographic relapse. PARP inhibitor monotherapy is recommended as a treatment option with a BRCA1 or 2 mutation. Mind you, this is talking about monotherapy, not about maintenance. So maintenance bevacizumab can be continued if used in combination with chemotherapy at a relapse, or the other options of maintenance PARP inhibitor can be administered. So very, very comprehensive and I would say a good guideline. So how does the PARP inhibitors work? I think Colonel Chaudhary has very lucidly, covered it entirely. What are the effects of PARP inhibitors and how they work on single standard breaks, and how in patients of, who have a PARP inhibitor, the role of synthetic lethality and how it actually acts. So wonderfully covered by my previous speaker. So I will not go into the details of how it works. But the concept was that we did see that there are certain PARP inhibitors who work even in BRCA non-mutated, cell lines. So there evolved the concept of is there certain amount of concentration of the drug which is required in which will help us for these drugs to act? And so for this, I think this slide shows that there are a lot of preclinical studies for early PARP inhibitors indicate that even in BRCA wild type cell lines, if the concentration of PARP inhibitor is given in a higher concentration, so they can have an anti-tumor effect. So probably this was one of those background knowledge which helped us in giving, niraparib also in patients, I believe, who were, BRCA wild type. So this is a good cartoon which depicts that, even in wild type, once you keep increasing the PARP inhibitor concentration, then there is certain amount of sensitivity which can be seen even in wild type tumors. So coming to this big question of when to use PARP inhibitors, but prior to that, I would just like to go to the recurrence. What are the overview of how we treat a recurrent disease? The most important modality that we keep the patient on follow-up is either by CA-125 or by CT scans. So if you have a serological relapse, you definitely get a CT scan and you look for a radiological relapse. So platinum refractory are those diseases who fail to achieve any PR2 therapy or in fact have grown while on therapy. Platinum resistant if the recurrence occurs within less than 6 months. Sensitives if they have been the recurrence is beyond 6 months. So there has been some kind of newer terms like platinum appropriate or platinum not appropriate. So this is how we have been doing. We can give, in the cases of relapse in a platinum sensitive disease, you can go for platinum doublet chemotherapy. If you have a germline mutation, you can go for a PARP inhibitor maintenance. If you have given bevacizumab as a part of the therapy, probably you can also go ahead with a bevacizumab maintenance. So this was a simple cartoon. But then the question always comes about, what is the difference between giving a maintenance of bevacizumab vis-a-vis giving a maintenance of the PARP inhibitors. So definitely we had some good outcomes with GOG 213 and Ocean's trial, where bevacizumab has been used in maintenance chemotherapy, and they gave a good amount of even PFS advantage of around 30 to 40, 35 months or somewhere. But if you have a germline mutation, then definitely with the PARP inhibitor, the PFS advantage is much more. The difference in the pathology is bevacizumab studies were allowed all histologies, whereas PARP inhibitors, we definitely are looking at a high-grade serous carcinomas, and more so the advantages had been more in a germline mutated patients. So FDA approval for PARP inhibitors, I think all of us know it has been approved, and this is the sequence of how all these drugs have been approved, both olaparib, rucaparib, niraparib, and also the approval with olaparib with bevacizumab in HRD positive first-line maintenance. So all these, I think the first-line trials have already been discussed. So we'll be coming to the role of PARP inhibitors in second-line and in relapse settings. So mainly 3 drugs that we are talking about. We are talking about olaparib, niraparib, and rucaparib. So olaparib, first-line maintenance therapy for BRCA mutated advanced breast ovarian cancer if they have a good response to platinum-based chemotherapy. First-line maintenance therapy in combination with bevacizumab for ovarian cancer who are having a good response to platinum-based therapy with an HRD positivity, as already has been discussed. Maintenance therapy for recurrent ovarian cancers in CR and PR to platinum-based chemotherapy regardless of BRCA mutation status. So this is also a place which actually needs more discussion and deliberation, but there is definitely a role here. And fourth line and beyond treatment for advanced ovarian cancers with germline BRCA mutation. So this is just talking about monotherapy. Regarding niraparib, first line maintenance therapy for advanced ovarian cancer in CR and PR, platinum-based CT regardless of the BRCA mutation status. So this is something which needs to be highlighted. Maintenance therapy for recurrent ovarian cancer in CR and PR to platinum-based chemotherapy regardless of BRCA mutation status, and fourth line mutation if you have an HRD positive. Rucaparib can be used as maintenance therapy for recurrent ovarian cancer in CR and PR based on post-platinum based therapy who has got a good response, but It is also regardless of BRCA mutation status. And third line and beyond, it can be used in germline BRCA mutated patients. So about these three drugs, bioavailability, niraparib, very good bioavailability, around 73%. Olaparib, I don't think it's available, it's not available. But what you see that the niraparib has got a good bioavailability and also a good tissue distribution, So probably this is the reason why perhaps the concentration in the tumor is much more of niraparib, and perhaps that could be one of the reasons why it acts even in BRCA wild type. So PARP inhibitors differ in their biochemical properties, hence data cannot be extrapolated from one PARP inhibitor to another, and each PARP inhibitor needs to be assessed based on its approved indication and data. And biochemical properties are not meant actually to suggest clinical efficacy. So very nice points. Coming to the dosing and dose modification, dose generally olaparib, 50 milligram, you have capsules. Tablets are under the strength of 100 and 150 milligram. They were initially used, in fact, in the first trial at a dose of 400 milligram BD, but now they generally but this is for the capsules, where the tablet we generally used are the 300 milligram twice daily. And definitely they have their own set of adverse reactions, as have already been brought up. They bring about anemia and for easy fatigability. So dose interruptions and dose reductions can be done. Similarly, rucaparib, they come under the various tablet strengths of 200, 250, and 300, and 600 BD is the dose. So we are supposed to do a baseline CBC and thereafter monthly, and dose interruption as and when required. Niraparib 300 milligram daily. They come in capsule strength of 100 milligram. CBC weekly for first month, then monthly for the next 11 months, and then periodically. And however, it has got its own cardiovascular side effects. So you have to monitor your BP and heart rate monthly for the first year. Now coming to the main trials. So the main trials were Study 19 and Solo 2, which studied olaparib versus placebo. And these were all patients where we have a recurrent ovarian, and most of them were in a platinum sensitive population. For niraparib, you had NOVA trial, and for your rucaparib, you had the ARIEL 3 trial. So what were the outcomes? Median PFS in Study 19 and Solo 2, Study 19, there was a PFS improvement of almost around 4 months. Here, there was a very good improvement of almost around 14 months, good hazard ratio. But this is primarily for the PFS advantage that we are looking at. In NOVA trial, niraparib, another very good advantage in germline BRCA mutated patient of almost around 16 months, very good hazard ratio of almost 0.27. Similarly, if we come to the ARIEL trial, rucaparib also showed very good advantage of increasing the PFS of almost around 10 months and with a very good PFS hazard ratios. So the activity of PARP inhibitors in ovarian cancer with BRCA mutations, BRCA status, if it is mutated, number of prior lines which have been given is actually more than 3. We need to highlight this, that after 3 lines of chemotherapy, we have actually to look into the PS of the patient also. But nevertheless, they had a good response. And similarly, in rucaparib, if they had the trials actually took a number of prior lines were almost more than 2. And here also they had a good overall response rate. And similarly for niraparib, they had the number of prior lines were generally greater than 3. So this is the first trial which actually got published, I believe, in NEJM 2012, which it was a phase 2 trial. And this was first of the trials which actually threw light on the advantages of using olaparib as maintenance therapy. So then came the Study 19, where also olaparib maintenance in platinum-sensitive recurrent ovarian cancers. So this was a randomized, double-blind phase 2 trial, which used olaparib 400 milligram BD versus placebo. And the treatment was given until disease progression, because this is in the relapse setting that we are talking about. The primary endpoint was PFS, secondary endpoint was OS, and extrapolatory endpoints were time to first subsequent therapy or death and time to second subsequent therapy and death. So we'll just see the trial formats and then we'll look at the results in one go. So here we have a study 19 PFS. The olaparib showed a very good advantage of median PFS improvement of around 4 months, and the curves have separated quite early, and they have, even after 12 months, there had been some separations. So, but in the, this is all patient, but if we are talking about the BRCA mutated patients, here the advantage has been around 8 months. Even the OS advantage, the first, initially there was no OS advantage of olaparib, but later on, follow-up trials had actually shown up that there definitely was an inclination towards improving the OS also. Now, the NOVA trial, which used niraparib maintenance in platinum-sensitive recurrent ovarian cancer. So here also they had divided into 2 cohorts. Either you had a germline mutation or you don't have a germline mutation. You're given either niraparib versus placebo, and the treatment was until death, until progression. So
my apologies, sir. You are left with just 1 minute to conclude.
Oh, I know. Okay, so you gave me a topic which is so vast. So, nevertheless, I think I would have, I in fact would move to my take-home messages only. So we all know that these have shown a lot of wonderful outcomes once we use. And as has already been discussed, there was definitely problems associated with MDS and formation of AML. But nevertheless, these with a good follow-up, I think we can keep a track of these any such kind of adverse events. So maybe I'll just come to the final slide. So we need to agree that the era of targeted therapy has definitely arrived. And with such a good, line of therapy that we have today, are combinations, and in fact, in the earlier uses of these drugs, would be much more better than keeping it up our sleeves and using it in the further lines. So the very good markers, biomarkers, which we can say we have HRD and BRCA, but other markers have been disappointing. And definitely going forward, the goal is to develop a very synergistic combination with PARP inhibitors for homologous recombinant proficient and PARP inhibitor resistant disease settings. So with this, I would like to thank and would be open to any questions if there are.
Thank you, Colonel Abhishek. It was a very wonderful talk, and you have simplified it very nicely. Even a layman can understand. You have covered the topic very nicely, and I congratulate you on this talk.
Thank you. Thank you.
And if any one question, we can, if it is there. But one thing which I came to know is even in BRCA non-mutated, these drugs do work. But the response is not so much as BRCA. But I think it is recommended for BRCA non-mutated, all these drugs.
So there are recommendations for
guidelines do recommend in BRCA non-mutated.
Niraparib is recommended, sir. In fact, that is recommended.
Even olaparib, they said.
Yes, yes, that is also. But I think that will always boil down to how our sense of are we ready for giving it to a non-mutated patient?
Then there will not be any point in getting all this BRCA testing done. We have to give we can give in both the things. But I think testing do suggest that the response will be better in BRCA mutated. Thank you very much, Abhishek.
Thank you.
It was a very wonderful talk.
Thank you.
And then now we will move on to the next, which is panel discussion. And I would invite Colonel Deepak Malaskar. He is the consultant medical oncology at the prestigious Army Hospital RNR. And he will be conducting the panel discussion on does HRD has the potential to become new BRCA. Colonel Deepak Malachkar, may I request to conduct the panel discussion?
Thank you so much, sir. A pleasure always. Okay. So I hope my slides are visible. So I have a great panel here, and I must say quite a young panel. I feel like an ancient sitting here, but here we are. So I have Kalnanesh with me, I have Dr. Deepan, Dr. Nayak, Dr. Manoj, Dr. Deepak, Dr. Vijay Prakash. I hope all of them are on board. So I have a small case in which we are looking at the female presented with abdominal distension, PM125 was raised.
Deepak, your voice is cutting.
Is it still cutting, sir, or am I audible?
Sir, you are audible, but there's some disturbance, sir. Like it's making your voice quite blurred or feeble.
If somebody else's this is open, background noise, even I am getting it. So if everything is all right.
Deepak sir, your voice is not audible, sir. We can't hear you.
So we have a hello.
Yes, sir. Now you are audible, sir.
Thank you. So we have a lady with a high-grade serous ovarian carcinoma. She had some adnexal masses, thoracic metastasis. She received about 3 cycles of NACT with paclitaxel carboplatin and subsequently underwent interval debulking surgery with bowel resection and splenectomy. And there was apparently R0 resection. The slide says no residual disease, so I'm presuming it was a very good response too, and probably a good surgery. Now, at this point, Dr. Deepan, are you there?
Yes, sir, I am here.
So, Dr. Deepan, what would you do now?
Sir, this is the case after finishing a adjuvant 3 cycles after surgery. I would like to document the response and the CF and 125 level. I would like to advise further genetic testings, BRCA1 and 2 testing on a tumor, whatever already had resected during surgery. And based on that, with the proceedings, I would go ahead, sir, based on the results.
Okay, based on the results. So would you continue with your 3 more cycles of chemotherapy first, or would you think that probably you're looking for genetic testing first?
Already 6 cycle is good enough, sir. After 3 cycles of chemotherapy, total 6 cycle, then I would like to proceed further based on results. If these are the mutant, then I would like to further based on the solo one. And if non-mutant, then I would like to put further based on the results of Paula one HRD testing. I would advise based on result. I would like to give option regarding further.
So you said first BRCA 1 and 2 somatic, right?
Sir.
Okay. So do you think genetic test wouldn't suffice in this?
So because the benefit of if what I would have gone for the genetic testing, sir, the yield of benefit for the patient in maintenance, first line maintenance, sir, there would be a nearly 16%, sir. With the somatic, I would add on the more nearly 8 to 10% more. So the patient would 1/4 of patient will benefit of this BRCA mutant cancer. Somatic analysis with 1/4 nearly. So proportion of patient with benefit with the PARP inhibitor therapy would be more based on data. So somatic I would go for first, sir.
Okay. So, and you would go for the HRD rather than going only for BRCA mutations, right?
Sir, sir.
And how much more percentage would you get out of doing a HRD more compared to just about BRCA?
It is already demonstrated in this meeting, sir, already. This one slide, sir. That showed always 50% cases which are the HRD deficient, sir. So half of them are the BRCA mutants, sir. So 25, if the BRCA is negative, then 25 will be more added to the list, sir.
So we look at it that way. It's about genetic BRCA would be around 8%, BRCA2 genetic would be 6%, I guess, and somatic would be 3% each for BRCA1, BRCA2. BRCA1 promoter methylation probably another 10%, and then we are left with somewhere around 19 to 20% that would be further picked up, what used to be called BRCA-like illness. Right?
Yes.
So we would like to go for a HRD testing. So Nair, Deepan has already answered this question that probably at this point of time, you would like to go for genetic testing. Other than BRCA testing, do you think there is any other markers that we need to test?
So we can try for HRD, sir. HRD, if the BRCA is negative, both germline and somatic, sir, we can try HRD, sir.
And we keep talking about immunotherapy in all other cancers. Why don't we speak of it in probably this kind of ovarian cancers? We don't seem to be talking about MSI. We don't seem to be talking of PD-L1. Any particular reason we have for that? Hello? Nair, have you got my question?
I guess, sir, he's not available.
Okay, so probably Dr. Shivashankara can take it. So do you think, why don't we speak of other mutations other than probably HRD and BRCA in ovarian cancer?
Sir, I mean, we do speak of MSI if it is a non-serous type, particularly if it is a clear cell or mucinous, then we do speak of
voice is breaking.
Okay. But in serous, what kind of makes it? Is it a tumor biology different that we don't speak at all of MSI or PD-L1?
Recurrent ovarian cancer, I think you are asking about.
Sorry, sir. I could not understand. I mean, there was some technical glitch in between. I could not hear the question.
I mean to say is in high-grade serous ovarian carcinomas, we don't seem to be speaking for MSI or anything. Do you think there's something in the tumor biology per se that MSI might not be a good test to do?
Probably, sir.
Okay, so most of the high-grade serous ovarian cancers are usually TP53 related and have chromosomal instability. So they are more of chromosomal instability which drives the tumors rather than the microsatellite instability. And both of them tend to become kind of mutually exclusive. And that's why the MSI testing in ovarian cancer is not that good a test to do in it. And considering that nearly about 50% would have some BRCA or BRCA-like biology, I think that is probably the reason why we are more, all of us are concentrating with HRD. So these are the mutations that we have. If you look at the MMR mutations, that forms only about 3%, compared to possibly HRD plus HRD would be a slightly more than 50% would be where we are concentrating. So these are probably the actionable ones that we are concentrating right now. So if I go back, Dr. Surya Prakash is there? Hello?
Sir, I think Dr. Surya Prakash sir is on emergency duty. Sir is not able to.
So Dr. Dubey?
Yes, sir.
Okay, so
Sir, first, before you ask me anything, sir, I would have your permission to say something on. You said that why this MSI should not be done in high grade serous. One point, because sir, extrapolating from colon cancers, if anyone is presenting with advanced CA ovary, the likelihood of MSI or defective mismatch repair is quite unlikely, because most of the, when in colon cancer also we have seen that most of the patients who are MSI high or DMMR, they are stage 2. In stage 2, it is seen in around 20% of the patient. In stage 4 and all, it is seen in just less than 5% of the patient. So mostly these MSI high patients generally should not actually present with such advanced stage. This I am just extrapolating from colon cancer. This is my point. Maybe I may be wrong, but I just wanted to know your opinion on it.
You're absolutely spot on. And that is why I said that most of these advanced high-grade serous ovarian cancers are driven more by chromosomal instability and TP53, and that is why probably we don't get it. Now, let us say we do HRD here, as Dr. Dipen has been proposing. So what is our aim in doing that? What are we looking at?
Sir, in HRD, sir, we are just looking for those patients. This is just a biomarker for guiding us that which are the patients who will be benefited with PARP inhibitor on the principles of synthetic lethality. Because just coming on this HRD is based on that genomic instability score, which is based on 3 things, that is a loss of heterozygosity, and then telomeric allelic insertions and large scale transitions. So it has been seen in the trials that patients who have like a certain cutoff of the HRD score, genomic instability score, that SCAR score, this is actually predictive of response to PARP inhibitor in Powler's. Otherwise, if the genetic mutations of HRR gene is being done, then these HRR mutated patient, actually it is not predictive of response to this PARP inhibitor. That's why we are doing HRDs.
Okay, so any biomarker has a prognostic significance and a predictive significance. So you have spoken about the prognostic significance, predictive significance. Do you think it has any prognostic significance per se?
Sir, I'm not sure that whether HRD should be of that prognostic significance, what BRCA1 and BRCA2, because BRCA1 and BRCA2 mutated ovarian cancer have long-term better overall survival. Like the 5-year overall survival is just ranging in more than 50% of the patient. I'm not sure that whether HRD positivity also gives them the similar survival advantage or not. So I should maybe some other panelists can tell this whether this HRD positivity also carries the same prognosis as BRCA1, BRCA2 mutated ovarian cancers carry.
Okay, so he's made my job easier. Dr. Manoj, he's passed the question to you.
Sir, still the data is again in this scenario, it's not so robust. So that is why we are just calling it, it is probably better than HR proficient, but not as good as BRCA1 positivity. So that lies in intermediate in between BRCA mutated versus HR proficient. So I'll say the exact numbers I'm not very sure, but it lies in between and it derives some benefit. Though all the trials and data is very positive for the BRCA.
My question is, if you have a, let's say, HRD positive patient, do you presume that his overall survival would be better than those who are HRD negative?
Yeah, I feel BRCA mutated will have a better survival, but as compared to proficient, HR proficient, OS will be definitely better.
Okay, so it does have both prognostic as well as predictive. And since the topic has focused since the beginning of this seminar on the predictive, but it also has a prognostic validation. And it also identifies the patients who are who do better over a long term. I think the numbers are about 30 months versus 50 months. just about the median survivals or the overall survivals, whether it is HRD positive or it is HR proficient. So that is about it. So now if we take about this slide, what it is trying to say is probably putting everything into perspective about what are the various biomarkers, and this has been discussed quite a bit till now. So SOLO-1 trial, this has already been discussed. Colonel Chaudhary took us through this into a very great detail. So is Colonel Anvesh around? Has Colonel Anvesh joined? Okay.
No, sir has also is not joined. Sir is also traveling.
He's enjoying his leave. So that's, I wanted to actually catch him today, but he's on leave for last 15 days, another 15 days, I think it will be on leave. So we must wish him good holidays. So coming back to Dipen, what would you now kind of select, which test would you select for this? I think you're already gone with tumor-based HRD scar test, right?
Yes, a tumor-based HRD scar test. I would have I would advise, sir.
Okay, so now these are the things that have already been spoken about the loss of heterozygosity, the telomeric allelic imbalance, and the large-scale state transitions. So you kind of combine the scores together, and so based on that score, the cutoff of 0.42 or 0.45, you base it on whether the patient is, kind of HRD positive or HRD-like tumors or BRCA-like tumors, or it is a BRCA non-mutant type or HRM or non-BRCA mutated type of tumors. So based on that, this is the overall in PAOLA-1. One must remember that PAOLA-1 was a prospective trial, but however, the subgroup analyses were exploratory in nature. So, but the data that we have from here is what we can presently share. So this has already been covered. Around about 48% are going to be HRD positive, and the remaining are going to be HRR or non-BRCA mutated type. So this identified about 19% of patients who are HRD positive, excluding the BRCA mutated. So we'll go for this. This cartoon here, I would like to depict. This is how my choice was done. You have 3 LOH scores, you have telomeric allelic imbalance score, and you have large scale state transition scores. If you take individual scores of them, then none of them seem to provide anything. But when you combine all these 3 scores, that is where you kind of get a cutoff which defines the patient who are HRD positive and those who are HRD negative. So that was the cutoff that was taken. It's a very nice cartoon. You can probably find it on the ESMO seminar on a similar topic, wherein they have actually shown us that how that cutoff was reached at. So it's a good thing to know. Now, if we look at the ESMO recommendations for homologous recombination, ESMO as well as other bodies have recommended for testing for HRD in this. So this is a question, Nair, where we kind of, do we do a reflex testing for germline if the tumor test is positive, or do we go the other way around? And why would you do that? Nair, you're around?
Am I audible, sir?
Yeah.
So the chance of germline mutation is more in ovarian cancer. BRCA germline mutation is more in ovarian cancer, around 15% of germline mutation compared to somatic mutation, which is around 4 to 5 to 6%. So if the germline mutation is positive, then there is a chance of somatic mutation. If the germline mutation is negative, then there is a chance of somatic mutation. So the reflex testing is indicated.
So what would you do first? Would you go ahead and do the HRD test upfront, or would you do a sequential test? Will first do a BRCA genetic test and then go on to a...
I'll go for a BRCA germline, then somatic, and then HRDs.
And why would you go to that?
Sir, if HRD is available, then the HRD can detect more cases, around 50% of the ovarian cancer we can. But HRD is HRD deficient, sir. So HRD scar test is often available, then we can go for HRD.
Dr. Shivshankara, what's your take on this?
Sir, first, whenever I'm ordering, I will like to answer two questions. Sir. First is, what is the indication why I am doing this test? So if it is, patient is affordable for a PARP inhibitor therapy, then my choice of test will be different. If patient is not affordable for PARP inhibitor therapy, then only for family screening, then my choice of test will be different. If patient is affordable for PARP inhibitor therapy, then I will upfront go for HRD scar test because it is freely available. Company will sponsor it. No need to pay. It will pick majority of patients. If HRD comes positive, they will also mention that in that HRD scar test whether it is a tumor BRCA mutated or not tumor BRCA mutated. So I'll get, if tumor BRCA is mutated, then I'll also do germline BRCA test only in those. If tumor BRCA is not mutated, then I'll not do germline BRCA at all in those patients. If my question is not to give PARP inhibitor, if patient is not at all affordable for that therapy, then I'll only do germline tumor.
So, in spite of having a prognostic significance, and as you are saying that you get a HRD test done free of cost, would you still not go ahead and do the test?
If company agrees that I will do it for prognostic purpose, then definitely I would like to have much more data, sir. Definitely, I would like to include all the patients because as you also brought it out that it is a surrogate marker for BRCA. It predicts a response. It is platinum sensitive or platinum resistant. That idea also we get on that. So definitely I'd like to include HRD test if it is available free.
Okay, so let us say, okay, so that we have that probably the rest of the panel probably agrees that they probably go ahead with the HRD scar test upfront. Dr. Dubey?
Sir, I would slightly differ in this, but maybe whatever Shivshankar has given the point, they are truly valid. But I would first order germline because that will not also be predictive prognostic, but also it will open a cascade for surveillance for other malignancies in that patient and also for risk stratification in the family members. And secondly, so if germline becomes positive, I don't have to do a tumor, this one HRD test. And if HRD test is positive also for tumor BRCA, then also I have to do germline to get to know that whether it is germline or it is somatic. So I will go with germline first, then HRD next, if germline is negative.
Okay. Dr. Manoj, with this patient, we have an upfront patient. But then we have some of those patients whom we have treated with Paclitaxel, carbo, 3 cycles and surgery, and subsequently, adjuvant on follow-up, probably only on bevacizumab. And the disease recurs, let's say, after a PFL treatment interval of about 2 years, right? So, do you think a rebiopsy is required to do for the BRCA HRD testing, or do you think the historical sample should suffice? Hello? Dr. Manoj, are you there? Okay, I think we are losing him. So, Dr. Deepan, you got my question?
Sorry, sir.
I say, let us say you have a recurrent disease. Recurrent disease has come after a TFI of 2 years, right?
Sir.
And so now, would you do a HRD on the initial test that you have, or do you think you should do a fresh biopsy and do the HRD on that?
Archival tissue is good enough according to me, sir. No need of fresh biopsy for the specifically HRD testing, sir.
Is Dr. Prashant Bagali with us?
Yes, sir. I am here. Yeah.
Sir, what is your take on this? Because you would be knowing more than all of us on this. What is your take on it? I mean, is the historical sample good enough, or let us say we have a relapse and we should be doing a fresh biopsy?
Yeah. So, like I shared earlier, sir, with regard to the quality, the QC criteria is very important. Like if because we always keep the 7 years of sample, and usually routinely all the labs keep the 7 years of FFP blocks with them and also, or some of them keep 7 months in their storage and all. So if the sample available with us, or if the biopsy FFP block is less than 1 year old, then we can still try to re-extract from that. If it is not matching to the the QC criteria, then we need to do the re-biopsy, sir.
And so one is how much of the tumor we are able, how much of the DNA we are able to extract to run the tests on it. One of the questions is that. The second question is it a stable mutation that occurs, or that will be constantly, there will be some mutations probably going on?
Correct. Yes, sir. Yes, sir. Because based on our experience is, since the genomic instability or a mutations will be a continuous process, either like two types of it, either they are responding to the therapy, which is where the patient is undergoing, or to the inherent genomic alterations which are happening in the body. So especially in the somatic tissues. So, and certainly there will be changes into that, so which will give the better clarity with regard to the variant identification and the interpretation of the clinical outcome of the patient sample.
I might be pestering you because I am a little unclear on this myself. So what I would like to know is, would a HRD positive patient in the initial test, subsequently when the disease progresses, would he turn out to be HRD negative? Can he turn out to be HRD negative?
Yes, yes, he can become the HRD positive, can become HRD negative. So the reasons may be, for example, HRD, the deficiency, the homologous repair one. So due either over the effects of the drug, whatever the repair deficit has happened, they might again start functioning normally. So in those situations, the kind of the score what we are getting will come within the cutoff point and all. So that's the one where in the olaparib also, now we are starting a clinical study where whether is there a patients which will follow some type of sensitivity or resistance to the olaparib like 6 months or within 1 year. That's what is, but there is no specific data that within what are those molecular signatures which are driving it to be converting from a HRD positive to HRD negative. But the possibility is always there, sir.
Yeah. So I think that is what the ESMO guidelines also bring out, that whenever you test, do the test on an archival, you're only getting a historical report, and it might not actually represent what is going on in the patient right now. So that caveat should always be kept in mind when we are planning to use a archival material. But in this case, as far as these two questions are concerned, most of our panel seem to agree that probably they'll do a HRD test, or probably do a BRCA test, genetic BRCA first, and if it is negative, do a HRD later. So I think it is up to the institutional practices and probably the socioeconomic conditions that will drive the decision most of the times. So anybody in the panel, Dr. Deepan, you have experience with tumor HRD scar testing?
No, sir. So far, I wouldn't have, I'm not experienced with the tumor HRD testings.
Okay. So Dr. Shiv Shankara, what about you?
So far we had asked HRD scar testing in 4 patients. Among them, 3 of them have come out that the sample, though the samples were just 3 months old, it has come that amplified DNA is not adequate.
Okay.
Though the tumor DNA percentage was 60-70%, still the amplifiable DNA is not adequate. So 3 has come that it is inadequate, and 1 has come positive, HRD positive. And that patient also had a germline BRCA mutation.
Okay. So Dr. Dubey?
No, sir, I am not having any experience with tumor HRD testing yet.
I think we need to sensitize our pathologists to this particular problem that we are facing. And like Dr. Prashant has already told us that probably we need to get our pathologists to standardize this. This we have seen it with lot many tests. Sometimes one or two patients of mine also, when we had sent for myriad testing, we had the same issues leading to rebiopsies, and then subsequently there was some talk with the our pathologist and next time we were able to fix the tissue properly. I think we need to involve our pathologists more, and we need to make them aware that probably the whole aim of the biopsy in certain cases might be to do genetic testing. So let us say this patient is BRCA mutated. So what would be your choice of therapy, Dr. Deepan?
Sir, if patient is a BRCA mutant, already sir
Tumor
answered.
BRCA mutated. Tumor
BRCA, sir. So already answered, sir. Though the data, the trial was conducted with the somatic, germline BRCA mutant, I would advise, I would give to a patient olaparib maintenance options.
Okay, and niraparib unfortunately is not available in
Not
India.
available, sir. Correct, sir.
Okay, so and would you prefer it with just about olaparib alone, or would you mix it with bevacizumab?
Sir, data is though the data also suggests that with the HRD positive, this patient will be HRD positive. I would also I can give options, sir. With along with the PARP inhibitor, Bev maintenance option. I also would like to discuss both options actually, sir.
Okay, so here we are. We have this Solo 1, Paula 1. Nair, which study would you take for putting your patient on either bevacizumab or olaparib plus bevacizumab?
Paula 1, sir.
Would go with olaparib alone?
If the bevacizumab is in combination, then Paula 1 study will take, sir. And
this patient is tumor BRCA mutated. What do you do?
sir, this patient, there is she achieved an optimal cytoreduction. So olaparib alone maintenance, sir. BRCA mutated.
Dr. Shivshankar, your take on this?
Sir, in this particular patient, I will just go for olaparib. Otherwise, in tumor, in the SOLA 1, both germline and the tumor BRCA mutated, both were included. So otherwise, if there was a suboptimal cytoreduction, if residual disease where we need to combine bevacizumab, in that case, we can continue bevacizumab also along with olaparib.
Generally, in this probably case, olaparib Solo 1 trial as your probably would be what is there. So, if he was, let us say, BRCA tumor BRCA wild type and HRD positive, Dr. Dubey, your take on it?
Sir, I will combine olaparib with bevacizumab only if I would have used bevacizumab in patients with advanced disease and with the high risk of recurrence like ascites, pleural effusion and all those things. And where I have to, like in the adjuvant setting or neoadjuvant setting, I had used bevacizumab. In this patient had R0 resection with just paclitaxel and carboplatin. So I'll continue 3 more cycles of paclitaxel and carboplatin, and for me, just olaparib will do.
Okay, but this patient, if we remember from the presentation, had about
Stage 4B.
Stage 4B disease. So in spite of that, you would go with only olaparib now?
Yes, sir. Because though there are high chances of recurrence, but the patient had R0 resection with just paclitaxel and carboplatin, and there's nothing which is compelling me to use bevacizumab even in the adjuvant setting, sir. Because it is having R0 resection, sir. If I would have used in neoadjuvant setting and then I would have gone for surgery, then I would have would have continued bevacizumab and then added olaparib. But now, as of now, just for the maintenance, I will not add bevacizumab to olaparib. Only if I would have used bevacizumab with chemotherapy, then I would have gone and combined bevacizumab plus olaparib in maintenance.
Yeah, okay. Is Dr. Manoj back?
Yes, sir.
Okay, so what's your take on this? So when would you use bevacizumab in first line?
already the panel or previous panelists have answered. High risk of recurrence in the setting of like advanced disease, stage 3, stage 4, especially most of the stage 4 with ascites and pleural effusion. In such situation, we add bevacizumab.
Okay. So I think that's a very sensible way to go ahead with it. And these are all your studies, but so irrespective of whether it was stage 4 or stage 3, there was benefit of olaparib as we can see in this arm, and even with PFS2 benefit was also there. So probably now that we have come to a time wherein, kind of testing for somatic or germline mutations should be done upfront, and then subsequently our decision is to add bevacizumab or add PARP inhibitor, and probably to guide us, we have about Paola Solo Prima trials to help us go through it. So with that, I think we have had a very good discussion, and our job was made easier by some excellent presentations which we had prior to this thing. I'd like to thank the panelists for a wonderful discussion and give it back to the organizing committee. Thank you.
Thank you. Thank you so much for the nice panel discussion. And due to some unavoidable circumstances, next speaker is not available. So I would request Dr. Colonel P. Suresh to give expert comments.
Thank you. Am I audible?
Sir, very much.
Okay. So big thank you to the organizers to give me the opportunity to say a few words on this aspect. I think it has been a wonderful educational experience with all the speakers as well as the panelists and the moderators giving such excellent talks and discussing the whole width of this topic, I would say. So to sum it up, I think one thing that is very clear to all of us is that PARP inhibitors are a very efficient mode of treatment in patients who have HRD or BRCA positivity. I think none of us are going to debate on that point. It is definitely a very, very useful mode of treatment. And I think it has proven its efficacy both in the first line as well as in the recurrent setting. So there are some differences of opinion as to when HRD testing should be done and whether it should be HRD and BRCA. There was some differences of opinion. So I think with the efficacy of the drug being proven in the first line and with the company sponsoring the test free of cost. So HRD testing is definitely available. All of us, whoever wants to get it done. And I would agree with Dr. Shivashankar Swami's perspective on this, that if it's a therapeutic indication, then HRD would be the ideal test to be done upfront. And if it is a non-therapeutic indication, if it is searching for a hereditary cancer syndrome, then BRCA testing would suffice. And as to initially doing germline BRCA testing, the issue would be if it's a therapeutic indication, then we miss about 5% of those somatic mutation patients for which we have to again repeat a somatic testing. So somatic testing initially covers up the therapeutic indication completely. BRCA, I think there was some questions on, General Kapoor had asked some questions on BRCA negative patients responding and is the drug indicated. I think with the advent of HRD, that question is sort of answered, that in the initial trials, what was considered as BRCA negative was probably these HRD positive patients who were responding. And with the availability of HRD, any HRD negative patients, I do not think any of the doctors who are on this panel here today would like to use these agents. So tolerance of the drugs, we have found that these drugs are decently tolerated. There are certain side effects of these drugs, and
without internet, check karo.
We have faced problems in the usage of this drug.
Connected without internet.
Still, overall, request whoever is speaking to mute himself. So there are issues, but I think overall we know that patients do tolerate this drug. and it is a drug which can be comfortably used in the patients. Bevacizumab, there have been some questions which have been put up in the chat box also regarding bevacizumab. So we all know that it has been used for many years, and we have been using it in the recurrent setting and finding good results, as mentioned by many of the panelists, in the setting of pleural effusion, ascites, and all that. But in the upfront setting, the overall, we have not been able to show an overall survival benefit. It is only a PFS benefit. And the comparison arms, we do not have single agent olaparib arm in the comparison arms in most of these trials. So we do not know olaparib versus olaparib plus bevacizumab, what would be the results. So that is a question which maybe will be answered later in some trials. So overall, I think it was a wonderful experience, and all of us have learned quite a lot. So thank you to the organizers and everybody for this excellent conference. Thank you.
Thank you, sir. Thank you so much. And now I would like to invite Dr. Shiv Shankar Swami for vote of thanks. Over to you, sir.
Thank you. And I must say it's been a great learning experience for all of us. And I also would like to reiterate that it has made us a step wiser in managing ovarian cancer patients. I would also like to thank General Kapoor sir for unfolding such a great academic feast, and also Colonel Suresh sir for crisp and crystal clear summarization and expert comments. I'd like to thank our esteemed faculty, Colonel G.S. Chaudhary sir, for outstanding oration on utility of HRD in management of first-line ovarian cancer patient, and our Colonel Abhishek Pathak sir for revisiting the management of relapsed ovarian cancer patients, and Dr. Prashant sir for bringing about the practical aspects of HRD testing. And also I'd like to thank our Dr. Deepak Mulachkar sir for guiding the discussion in a right way, and also bringing out a lot of practical implications which we face while managing ovarian cancer patients, and our faculty, our panelist, Dr. Manoj Mahajan sir, Dr. A.P. Dubey sir, Dr. Nair sir, Dr. Dipin Bua for providing a very insightful thoughts and making the panel discussion very thought-provoking. And also I'd like to thank all the participants for taking out time despite their busy schedule to make this event a very successful event. And at last, I'd like to, without the sponsors, the event wouldn't have been possible. I'd like to thank the AstraZeneca, Zymera, and Strand for providing this opportunity and creating this platform to have such scientific discussions. With this, I conclude, and thank you, everyone.
Thank you, everyone, and good night.